Thanks. It's great to be here. I wish I were there in person, but you know, we do the best we can under very trying times. So yeah, I was charged to talk about inflammation, and so that was a great setup. The last question. Here are my disclosures. Those are the objectives. Those should be in your packet. I believe you have a copy of the slides. And so this is an overview of the pathology or the pathophysiology of what happens in the CF lung. We have the abnormal gene, which then gives us the abnormal protein. And this is where modulators work, or right in here. And then we have the abnormal salt and water in the airway. And this leads to obstruction of the airways, infection with bacteria such as Pseudomonas and Staph aureus, and inflammation. And these three things cycle on each other. And eventually you get damage to the lung airways themselves. And so this is called bronchiectasis. It's when the chemicals and proteins in the airway damage the individual's own airway walls. And we're going to focus here. This is going to be my charge for the next several minutes, is to give you an update on anti-inflammatory agents. So I guess the first question is, in the era of highly effective modulators, do we need anti-inflammatory drugs? Are they necessary? If so, why? And so I'm gonna try to demonstrate that yes, I think they're still going to be necessary until we have a one-time cure. But first, I want to go over an overview of inflammation. Inflammation starts early in life. We know it happens in the first year of life. It starts out small and builds upon itself. We know it is the primary cause of the lung damage. It's actually not the bacteria, but the inflammatory response to the bacteria. And the cells that are a particular problem are called neutrophils. And these cells, you've heard of white blood cells, and those are the cells that help fight infection, but neutrophils are a type of white blood cell, and you can see them. They're these here with the three different lobes of the nucleus. Those are neutrophils. Macrophages also play a role. Those are these big cells here, and these are very activated macrophages. Normally, when you do a wash of the lungs, you don't see any neutrophils and quiescent macrophages. And this is a picture of bronchoalveolar lavage fluid from a baby with CF who we did a bail on just to get cultures. She was having a G-tube placed, and we thought, well, this will be a great time to take advantage of the anesthesia and get cultures. We found no bacteria, no viruses, but she already had a lot of inflammation. Other things about the inflammation in CF, it appears to be out of proportion to the number of bacteria, and there's been a lot of studies that show that the neutrophil count and the inflammatory proteins are much higher in people with CF than, say, people with out CF who have a bacterial pneumonia. And in fact, that if you can eradicate the bacterial infection and do a bio afterwards, you see that the inflammation persists after the bacteria are gone. And there's some data to show that the inflammation may be directly related to the abnormal protein or gene. This here is just an airway, and what you see, this is the airway wall here, and this is a big mucus plug blocking that airway, and you see all these purple dots here and around the airways. Those are actually neutrophils, and those are causing a lot of problems. And so what's the data to show that inflammation begins early in life? This is from a study in Australia called Arrest CF, and they did bronchoalveolar lavage on babies at 3 months of age, and then did CT scans at 12 months of age. And they looked for a protein released by the neutrophils called elastase, and this is basically an enzyme that chews on the airway walls. And that the children who had more elastase were more likely to have damage to their airway walls at 9 months later. So this is doing the BAL at 3 months of age and looking at 12 months of age. And that also continued until the 3rd birthday and even out now till 6 years of life. So clearly any therapy we have to reduce the problems with CF lung disease is going to have to address the neutrophil and its products, particularly the elastase. So eventually we're going to have highly effective modulator therapy for people with CF, and that's all the blue here as we work down to lower age groups. 5%, this group here, these are people that have 2 of those class 1 mutations. Those are the ones that are called nonsense mutation. They don't make any protein at all, so modulators can't correct an abnormal protein if the protein isn't made. And then there's 5% who have rare lung disease, but there's also many people in this group who modulators may not be as effective in them as they are other people, or who don't tolerate the modulators because of side effect. So we're really going to have to continue to do research and address these other problems in CF. And also, what about the people with established disease? If you're 45 years old and you've already got bronchiectasis and inflammation, modulators aren't going to reverse that. So you're going to still have to treat the other parts of the lung pathology, the inflammation, the infection. And there is a commitment from the CF Foundation. Their mission is to cure cystic fibrosis and to provide all people with CF the opportunity to lead full and productive lives. So the question is if a modulator works pretty well up here, it should decrease all these things down here. And is that true? Is it not true? Or do we not know the answer? Yes. And I think, yeah, I think the answer is they're so new, we don't know for sure, but there is some data. And so this is looking at patients who had G551D and were treated with Kalydeco. And there was they studied these patients for 6 months, and there was a decrease in the CF bacterial burden in these patients overall. This is before they started, this is ending, so things went in this direction, which is good. But if you look at the inflammatory proteins, it doesn't really matter what these are, but what you see is these are all what we call pro-inflammatory, meaning they promote the inflammatory response. There's really no change. And then there was another similar study by Katie Heiser when she was in Seattle with a group at an Ireland center. And she kind of replicated this, and she actually showed that in the first 6 months, bacteria decreased and inflammation decreased as well. So it was a little different, but after 6 months, she followed these patients out to 3 years. They started, the infection went up, and guess what? The inflammatory mediators went up to follow it. So they were so they seemed to escape the original 6 months decrement, and they were back at their pre-modulator level. So this tells us that we're probably going to need anti-inflammatories even in the era of highly effective modulators. And so I want to show this. I'm pretty sure that most people on this know about the FEV1, and because we emphasize it at every clinic visit. And this is just a curve that we drew by freehand. And people as they age who don't have CF or any lung disease, there's a slight decrease as you get older and your tissues get a little more loose and your tissues get a little older. And in CF, because of the obstruction, infection, inflammation, there's a much more sharp decline. Now, this was drawn in 1997, so the curve comes out a little more. But really the purpose of this is to say, if we stopped here and we said, if we find a cure, what's going to happen to the lung function? Well, it should be relatively stable. If we have a therapy here where it gives us a bump in the FEV1, so we get an increase, but then the rate of decline, so if you remember high school mathematics and slope, is the same, well, you can see that's going to help some. It's going to get you out here, but that's only some things. that's not very helpful. If you have something that changes the rate of decline, that obviously helps out even more, right? So, you know, these therapies are all valuable and all useful in CF, but ultimately we want to get the cure. And until then, we really want to slow this decline in lung function down. So what goes on with the modulators? And so this is, I want to focus on the right here was a model done, or an analysis done by Greg Sawicki at Boston Children's. And if you look here, this is patients with Delta F508, 2 copies without modulator therapy. So this was done before Trikafta or Orkambi. And what you see is they had a certain rate of decline. And if you look at the G551D patients, their decline was much slower, but yet there was still a decline, right? It's not going straight across. It's dropping. So it looks like the modulators have slowed down inflammation, but it's still there. And the longer it's there and the longer it's causing damage, it's eventually going to continue that rate of decline, although it will hopefully, we think, be at a much slower level. So again, more data that even with modulators, we're going to need anti-inflammatory drugs. And so this is the CF pipeline, and what I actually, high-dose ibuprofen was actually developed by Mike Constant in Cleveland in the late 1980s, early 1990s, and that is currently available. We'll talk a little bit about that. And there were, as of April 30th, there were these 5 other drugs. Asbilostat was in phase 2 testing. Lonabosum was in phase 2 testing, going in between phase 2 and phase 3. Lao-7B as a phenretinine derivative is in phase 2 testing. And these 2 other therapies down here are in phase 1. And we're going to go over each of these in a little bit. So I want to start with ibuprofen because this is really one of the first studies that show that anti-inflammatory therapy is beneficial. So this is the original study by Mike Constant that was published in 1995. It was a 4-year study, double-blind, placebo-controlled, of around 100 patients between the ages of 5 and 39. And that's when you do these studies where you look at the change in the slope of lung function decline. They take a long period of time or a lot of patients, usually both. And what Mike found was, and this is back in the late 1980s, you can see that people on average lost 3.5 points every year in their FEV1. But you have to remember, in the 1980s, there were no CF-specific therapies. There was no pulmozyme, no Toby, no modulators, no azithromycin. This was just basically good nutrition and hospitalization or antibiotics. And so you can see that when you added ibuprofen to that, you can see that there was a much slower decrease. It didn't return it to 0, but the decrease in the rate of decline was much slower. Now, intent to treat is just a way we do studies, and anybody who takes 1 dose is in the analysis. So even if they don't take 1 dose and didn't take the other 99% of doses, they were included here. If they looked at people who took 70% of the doses of both the placebo and ibuprofen, you see that it's even better, and that the best group was the children. And that makes sense because the children have the most to lose, right? They have the healthiest lungs, so if you can slow the inflammation down early and carry it through, it should be more beneficial. And in fact, when they did a slope analysis, you can see here's the placebo group, and they're this way, and here's the ibuprofen treated group, and it's much slower. They had a 90% slowing in the rate of decline, and it was highly statistically significant. And then, excuse me, Dr. Constant published a follow-up study in 2018, and now, instead of losing 3.5% points per year, people were under 2 percentage points per year on average in the pre-modulator era. And so, which is much better, but still not perfect. So then Dr. Constant looked at using the CF Foundation registry, and here's patients who were not on high dose ibuprofen. They were lost about 1.8%, 1.8 points on their FEV1 every year. The ibuprofen group was right about 1. And then if you look at survival, and these are people who only took 2 years of ibuprofen or more of high dose ibuprofen, they actually had an impact on survival, and that the patients treated with high dose ibuprofen had better survival. So you would think everybody's taking that, right? And the answer is no. In its peak, that paper in the New England Journal was published in 1995, and about 15% of patients were prescribed it. And here is picking up, this is the Foundation registry, looking at anti-inflammatory drugs, and you can see this, this marked decrease. So now less than 3% of people who are eligible for it are being prescribed it. This is an anti-inflammatory therapy. This is lung therapy. So why is that? Well, the summary is when used appropriately, ibuprofen slows progression of lung disease. There is a small increase in GI bleeds. It's 2 to 3 times normal, but the amount of risk, absolute risk, is small. And so what this attributed risk is you would have to treat 375 patients with high dose ibuprofen to have 1 patient have a GI bleed due to high dose ibuprofen. It's even, I did this analysis years ago, it's even much different now because we weren't prescribing things like omeprazole in those days as a GI protectant. I haven't seen a GI bleed since the 1990s in a patient who was being treated with high dose ibuprofen. And so the benefits far outweigh the risk in young children relatively well. And the Foundation guidelines and the Cochrane database report said cryonic ibuprofen is recommended for children by the CF pulmonary guidelines and Cochrane collaboration. The reason it says this is a lot of people are wondering, since the biggest effect was seen in children, should adults take it? My personal feeling is you don't know who was going to respond to high dose ibuprofen, so there's nothing magical about 18, and if a patient's tolerating it, why would you stop it? So why aren't people prescribing it? Well, some people just don't believe the data. There are some concerns regarding safety. The GI bleeds, although I showed you that's pretty small. I think the 2 biggest things are you have to do blood draws every other year to see how a patient's liver processes ibuprofen, and that's committing a patient to a 3-hour visit. And then there's also, when this was approved, ibuprofen had just gone generic. So no company's gonna promote this therapy because you have 70,000 people worldwide, 30,000 in the US with CF, and ibuprofen is sold to millions of people every day for headaches and muscle pain. So no one's gonna go out and promote this. And so, but the CF community has long recognized a need for anti-inflammatory therapies. And I call this the Boulevard of Broken Dreams. These are all the therapies that have been studied at some point in CF, either in mouse models or the underlying ones are in human trials. And you see ibuprofen here, you'll see Pulmozyme here, azithromycin, and then pretty much everything else has fallen by the wayside. So these drugs just haven't panned out. But if you look at most of these drugs, there's a teeter-totter of, when you look at inflammation in the body. All of us get inflammation, right? We get an infection in our finger, it turns red and swollen, that's inflammation. And so when that happens, you have to activate your inflammatory arm to get that infection under control in your finger. But then when it's done cleaning up, you got to turn this off. So there's an arm that terminates that response and brings us back into balance. And what I want to say is most of these, we're trying to attack activation and bring it down. And so we'll talk, was that the right strategy? I do want to go on and present some data from a study that was done several years ago. And the study was of Bill 284BS. This was an international study of 600 patients, and it was stopped after 420 because of this. This is looking at time to exacerbation. Here's adults that got placebo, and adults who got the drug got had more exacerbations. And we think that's because they literally tried to eliminate one inflammatory mediator instead of getting it back in tune. And it's never good to try to eliminate something in its entirety. That mediator is there for a reason. And so CF inflammation is a nuanced target. And we know that the inflammatory response has long-term negative consequence for CF lung disease. But it also helps to keep the infection in check, especially early on in the disease. So as opposed to infection or the sticky mucus, where the goal is to just completely eliminate it, with the inflammatory response, we don't want to completely eliminate it. We want to just tone it back so it's not as aggressive. And so that causes difficulties in developing new drugs. So inflammation is excessive in CF. Ibuprofen is the only recommended drug, but less than 5% of people take it. And so new drugs are desperately needed. To date, most anti-inflammatory drugs have been directed at turning off that activation arm. Maybe rather than turn it off, we should up the termination arm, activate that arm. And so this is looking at what happens in CF. So the bacteria come in the airway, it gets activated, and instead of getting things under control and coming back down, it just goes up and it stays at this high level. So we got to find a way to turn this back off. And so I'm going to go over 5 drugs that are in development right now. These 3 all work by activating the termination arm. This one's a new one that works on an enzyme. Those 4 are all general anti-inflammatories, and this one is a specific inhibitor of that elastase that we talked about, released by the neutrophil. And so the first one's abelistat, and this was made by Celtaxis, and basically it inhibited an enzyme in a cell pathway in inflammation. And so instead of more inflammation being produced, by blocking this, it formed this compound to go down this arm, which helped resolve the inflammatory response. So it promoted the production of the resolution arm and inhibited the production of the activation arm. So the study was done and the results were published, have not been published, were presented at last year's CF meeting. And basically this, they were looking at the change in FEV1, and that was their primary endpoint. And their secondary endpoint was looking at exacerbation rate and how long it takes to get an exacerbation. And this was a year-long study, and it was in approximately 200 patients, age 18 to 30. Now, I will tell you, when I was in Cleveland, they came and they met with me, and they asked what I thought about this, using FEV1 as their primary endpoint. I told them I was concerned because they were based it on the ibuprofen study, which was at this point 30 years old. And I said, we have all these changes from these new therapies, and people don't have as rapid rate of decline. And first of all, even in ibuprofen, you would need to study 400 patients for a year. And so here you're only studying 200 patients for a year. And I said, I really think where you're going to see your signals here in exacerbations. That's your best bet. So they went on and didn't listen to me. So, oops, sorry. So they did not see a signal. There was no difference in the FEV1 in that study. And as I said, you would have predicted that. But when they went back and looked, and they looked at patients who in the year prior to being in the trial that had one exacerbation, and looked at those patients that were in the trial. And lo and behold, that when you looked at all patients, there was a big difference. This is exacerbation free, not number of exacerbations. Almost 50% had no exacerbations, and here only 25%. And that was held true even when patients were on modulators and even with patients who weren't on modulators. So this tells you that this looks like a drug effect from the asbilostat. So I was actually, to be honest, I thought, okay, they didn't hit their primary endpoint. I didn't think they will, but they did look to reduce exacerbations. And so they had sent out a survey in January, the team at Celtaxis, and we said we'd be interested in participating in the follow-up study. And then 3 months went by and we didn't hear anything. And then some things happened. So here you can see I pulled this up on July 12th. Celtaxis, so this happened. There's commentators who in the investment world who will put out their opinions. And so their opinions came out, and this is one of, says Celtaxis drug trial and CF fails. I don't think it failed, but that's what it came out, despite the positive spin put on by the company, which again, I don't think they failed. But this made investors so scary that the investors backed out of this. And then if you go to the Celtaxis page, and so I circled it here at www.celtaxis.com, their website's completely gone. And then when you go to the CF Foundation's pipeline, you can see that that's been removed. I looked up on LinkedIn what all the management of Celtaxis is doing, and they all have gotten jobs at different companies. And so there was no press release, nothing. It just overnight evaporated. And I'm a little concerned that because of the endpoint they chose, that the baby may have been thrown out with the bathwater in this situation. I think there still could be some benefit there. So next I want to talk about linabisum. You can see it says anabisum here, but it's actually been changed to linabisum. This is another drug that promotes resolution of the inflammatory response. And so it again triggers that down and brings things back into normal. And so we did a very early study on this, and it was really a safety study, seeing if the drug was tolerable and safe. We also did look at exacerbations, but as a safety measure, making sure that the drug didn't cause an increase in exacerbations. And then we looked at measures of inflammation in sputum in a subset of patients. And the trial was very simple. For the first month, patients got either placebo or low dose. This is a dose that we figured wouldn't have any effect. And they did this for a month because we're trying to create a range. And then they crossed over into 20 milligrams once a day or 20 milligrams twice a day. And the placebo group kept through. And so this was 2 months of treatment. And what we found was that there were fewer exacerbations in the patients treated with linabisum when you looked at time to exacerbation. But also when you looked at the number of exacerbations, in the first 4 weeks, which I didn't think we'd see any difference because that was a dose below what we thought was therapeutic. Again, and it didn't reach significance, but the overall number was decreased. And here, in the higher dose group, and again, didn't reach significant, but there looks like a dose response effect here. We did not have enough subjects in the study to look at exacerbations as an outcome. That wasn't the point. It was a safety study. So this was interesting because we were looking at exacerbations as a safety measure. And one of the things when we started looking at markers of inflammation in sputum, and I told the company, you're never going to see anything in sputum. It's just not long enough. We think you need 4 months of treatment. Interestingly, I was wrong in that they actually did see, this all means a decrease in inflammation. If anything on this side means an increase. And you can see there was a decrease in every inflammatory marker we looked at. Now, some of them didn't reach statistical significance, but we just missed IL-8's decrease, Immunoglobulin is decreased, and neutrophil elastase. So it does look like that the linabacim decreases inflammatory mediators. And it was well tolerated. There were no severe or serious AEs in the study. That's adverse events that were due to linabacim. And the only thing that occurred in a higher proportion is dry mouth. And that's probably related to the mechanism of the drug. No placebo patients complained of it. 13% of the linabacim treated subjects did. And so overall, we thought this was positive. And so we're currently wrapping up the next study. This is a 28-week, so half a year study where we're looking at 20 milligrams twice a day and comparing it to 5 milligrams twice a day, again, to create a range. And this study just closed out, so we'll be analyzing this data in September. And so basically you come in, you get randomized either to placebo, low dose, or high dose, and then we have follow-up. And our primary outcome for this is exacerbations. And so we're going to see if we had an impact on exacerbations. And that's what this slide says. The next drug is LAU7B. I see I only have a few minutes left. This is another anti-inflammatory drug that works by bringing the inflammatory response back into equilibrium. So this is pro-inflammatory, this is anti-inflammatory, and in CF, this is decrease, this is increase, and this drug kind of balances out this teeter-totter to get us over the hump. The other nice thing it does, in addition to resolving inflammation, is it actually turns out it also stabilizes the CFTR channel in the membrane. So it could have two beneficial effects. This is a very short study where they looked at inflammatory mediators, and IL-6 and IL-8 and neutrophils are on the activation side, and the linabacim drug decreased those. IL-10 is actually on the resolving side, and it increased those. But this is very preliminary data, and the numbers are small, right? 2, 4, 30, so small numbers. So we don't know if that's going to hold out. So that led to the current study, which is going on now. And basically, patients are going to get screened, 68 patients in the treatment arm and 68 patients in the placebo arm. That's going to be in adults who have moderate to minimal lung disease. And so that study's ongoing, and we're excited to see what happens. Calithera is just another general anti-inflammatory. This inhibits a different enzyme in the inflammatory response. This trial hasn't gone off yet because of COVID. It was all queued up, and now it's on pause. So hopefully we can get this one going up. And as I said, the neutrophil in the CF1 causes a lot of problems. One of it makes this elastase, which causes all of these problems. But the big one is the structural damage here to the airway. So even if we can reduce the inflammation, there's still going to be some of this around. And so there is a study that is going on in Europe looking at a small molecule that you would breathe in a nebulizer that would inhibit that elastase. And so they completed a phase 1 study in healthy volunteers, and now they're doing a phase 1B, 2A study in people with CF in Europe. So keep our fingers crossed there. You heard Marie just talk about stem cell therapy. And this is what Marie was talking about, is there's different kinds of stem cells. And these are the kind where you can go in and fix the GF mutation and give it back, and they'll have new lung tissue. But there's also another kind called mesenchymal stem cells. And these are stem cells, to be honest, they should be called signaling cells, because though technically they meet the biologic criteria for stem cells, they really monitor the environment and respond to it. And maybe these can be used as a treatment for inflammation and infection. And in fact, when I was in Cleveland, we actually just completed the study before I left. It was a phase 1 safety study in adults. This is the very first patient that got injected with it. Yeah, we have his permission to use his likeness. And I can tell you, we're in the process of writing this up. There were no safety events, no safety problems that were severe or unexpected. And so we will hopefully be designing the next study after that. So in summary, inflammation is excessive in CF. Ibuprofen is the only recommended drug, but is prescribed in less than 5% of patients. So far, most clinical trials haven't given us new compounds, but that's because they likely were directed at the activation arm. Maybe we need to develop them for the termination arm. Even though the CF modulators don't look like they have an impact, I think they do. It's just that we didn't study them long enough. And then maybe you still need the modulator and the anti-inflammatory drug together to get the biggest bang for your buck. They help each other out. And so we're going to continue to do research, and we're going to continue to develop therapies, even in the area of modulators, until we have a one-time cure. So I always get asked this: what is it going to look like, an anti-inflammatory regimen? I think you're going to need a modulator for your genes. I think you're going to need an anti-inflammatory drug. And then based upon what's going on in your area, you might have to take some specific inhibitor of some of the proteins and molecules still down in your airway. So the CF community is going to continue to grow, which is great. We're still going to need these symptomatic therapies like antibiotics and anti-inflammatories. And the CF Foundation recognizes that, and they are continuing to fund research in infection, inflammation, mucus clearance, and GI disorders.